Hello, it's Jim Huddy here, Cornwall CCG Clinical Lead for Chronic Pain, and I'm introducing the first of a two-part series of information and advice for GPs, logistical and consultation skill advice for use with opioid patients, and this one is to do with deprescribing opioids. I've been working in collaboration with Secondary Care, Dr. Keith Mitchell from the Pain Clinic, Adrian Flynn, Consultant Liaison Psychiatrist, and Paul Thornton, who's a gastroenterologist. I'm going to quickly summarise what we said in our previous video from the summer of 2017. The work we've done is published on the Cornwall Formulary website. The link's down at the bottom left of the page. We've got detailed information for patients where they can download and use this document electronically, which tells them all about chronic pain and how to employ self-management, which is a good, wholesome, sensible alternative to medications for use in chronic pain. Similarly, we've got a very thorough, quite long electronic Word document for use by clinicians, which will tell you all things you need to know about managing chronic pain, but it is quite heavy, which is why we are doing these videos. The video from last summer, as I previously mentioned, is on this page. We've also got some new documents that you can use. The first one's a one-page flyer that you can print and give to patients, which explains to them how to get to the patient information that I've described earlier. If you're thinking of trying opioids, and actually the second video in this series is going to be all about that, but there's some written information there with an opioid contract. The third article is more relevant to this video. If you're tapering or stopping opioids, it's written information to explain to patients why we think that's a good idea, so they can read that before you embark. If you want to write to patients to contact them when they're on opioids, there's a suggested letter there, and also some information that you can give to patients who are on weaker medications. Just to quickly summarise what's happening down here in Cornwall, we're a fairly heavy prescriber of opioids. We're on about the 70th centile, and we spend £3.3 million a year on these drugs. This stacked histogram shows what drugs contribute to the oral morphine equivalent prescribing burden, you might call it, for Cornwall as a whole. Here you can see the oral morphine equivalent prescriptions by each GP surgery in Cornwall. Very, very big variability in prescribing habits. Let's remind ourselves of the benefits of opioids for chronic pain. Well, there isn't any evidence for benefits of opioids in chronic pain. The randomised controlled trials are all of less than 3 months. The methodology is flawed, and they do show some benefit in the short term, but over 12 weeks there's no RCT evidence, and in the extension trials we think that some patients benefit minimally in the long term but without improvement in function. Regarding the risks of opioids, I'll cover that later. We think that reducing Cornwall's heavy prescribing of opioid analgesics is clinically and ethically justified. Righty-ho, so to the matter in hand, deprescribing opioids in primary care. We hope that having watched this you'll be able to develop a practice strategy for opioids. Well, we think that the basic strategy is to try and keep things as simple as possible. You could consider your patient group as the high-dose strong drug patients, the lower dose strong drug patients, and then the weak drug patients. You can choose one of these groups or all of them. We'll show you how to make a plan, and then you can audit how you've got on. You might have already heard that 120 milligrams is the dose that we use as a kind of cut-off, as a national speed limit, as it were, for dosing in chronic pain, because this is the dose that the Opioids Aware website from the Faculty of Pain Medicine, this is the dose that's been declared to be pretty much definitely more harm than good in the context of chronic pain. This can be made up of multiple drugs. There are calculators to help you work out the total oral morphine equivalent dose. But over 120 is too much. Quite often less than 120 is too much. So remember, 120 is plenty. So how many of each group have you got? Well, estimating from the prescribing team's data and also an in-house audit that we did at Perranporth, there are some very low prescribing practices, medium and high prescribing practices. So for patients over 120 milligrams, you've probably got between 0 and 40 per 10,000 population. Lower dose strong drug patients, probably between 20 and 200 we're guessing, and maybe between 500 and 1,000 patients on weak opioids. That depends on your demographics and prescribing habits, and that's versus about 1,500 hypertensives, to put it into perspective. So going back to our patient groups, which ones are you going to tackle first? So there's different options, but obviously you want to maximise your return on investment. You want to make sure that the time, money and effort that you put into this translates into the maximum benefit for patients. Should you concentrate on the high dose patients because their risk of harm is highest, because their numbers aren't too overwhelming, and you'll probably know their cases quite well. There's potential to make significant reduction to prescribing, and successes can be highly rewarding. However, we all know that some of these patients can be very resistant to change, and they are time and energy sapping. And you're going to need a lot of resilience to get through these consultations. They know your practice systems and weak points well, and you might end up feeling a bit nihilistic about things. You might have to pick your battles carefully. The lower dose strong drug patients, well, they might be more amenable to change. They might be less draining on your resources. You might have more success, and they are a large part of your prescribing mass. Although we're guessing with all of this, and I think that's depends on case by case situations. There are a lot of them, on the other hand, and a lot of them may well have characteristics of the high dose patients. How about patients on weak opioids? They might be the most amenable to change, and they might require the least individual input, although there are a lot of them. And how hard are you going to push them if they're not so motivated? There's some logistical questions as well about how you're going to contact them. Posting letters to them is going to be expensive. Ultimately, we think that when it comes to return on investment, engaging the patients who are most motivated to change will be rewarding, although obviously we can't ignore those who are less motivated. Let's consider now some logistical and consultation skills strategies for patients on strong opioids. So how did we get into this prescribing mess? Well, for patients with chronic pain, we've often not known the non-drug treatment, which we know now to be self-management. And when we were trained, we were taught that escalating the dose is likely to cause long-term benefit. We now know that not to be true, and we also were told that patients wouldn't get addicted, but up to a third do in some series. Why is it so difficult? Why is this so difficult? Well, we're using a treatment for a condition that is relapsing and remitting by nature. And the problem is, if you think about it, that the opioid treatment can cause pretty much all of the same symptoms as the condition as itself. It can cause pain, it can cause distress and depression and loss of function. So should we start opioids? Should we reduce the dose? Should we increase the dose? Should we use a slow release formula or an immediate release formula or a patch? Should we reduce and have a drug holiday? But when their pain flares up, does that mean that the analgesics are actually working? Are they going to get dependent and addicted? Am I going to add to their problems? Are they going to overdose and die and I'll get struck off? So we've got to wind back the harms that we've done. How are we going to do that? We've got to find the patients, we've got to provide continuity of care and continuity of documentation. We've got to contact them, we've got to see them, we've got to encourage and follow the cycle of change, then start a tapering process with regular reviews and take advice when needed. Well, that's one way of doing it. People have suggested to me that it's a little bit too soft and a harder line may be more effective and equally ethical. We'll talk about that a bit more later with this fantastic slide. How do we find these patients? Well, GPs have been searching their IT systems for many years, doing audits, and just remember to try and make things watertight as regards the fact that many patients will be on multiple drugs. So, for example, 25 mics of fentanyl plus 30 of morphine plus some tramadol on top. Individually, none of those would hit the 120 milligram bar, but together they would do. Continuity of care is very challenging nowadays because a lot of us only work half time. So if you've got a shared list, consider a buddy system. So for example, if I work Mondays and Wednesday, my clinical colleague works Tuesday, Thursday, Fridays, then between the two of us we cover the whole week. So opioid prescribing can be taken on and only taken on by myself and my buddy. We're the only ones allowed to prescribe to these patients. You can share out the patients, try and accommodate their wishes if you wish, and have some clear pop-ups on the home screen. Regarding continuity of documentation, if you use a term that can be searched for, then it can bring up the opioid story easily to hand. So for example, in System 1 we've got a template in the Arden's templates, which is under auto consultation, then monitoring, then opiates, and you can input all sorts of information here, from an opioid trial to opioid tapering and side effects, etc. And then in the future, if I search for the word opiates, then it brings up all of these clinical or administrative consultations for me to see very simply. I can't really comment on whether EMIS or microtest systems have a similar capability, but I'm sure you can team up with some colleagues to design one. Possibly the CCG might be able to input into that. So when if you want to contact the patients, we've got a suggested letter, which is number 4 of our documents on the Cornwall Formulary website. Here's the letter that explains the rationale for considering a reduction in dose, and also it gives the flyer to the patient information on the formulary website. You might want to contact them opportunistically when there's a 1 out of 1 repeat that's due, or by text messaging, or by mail shotting with the letter that we've shown you. But please remember that for many of these patients, their lives are run by these medications and the next dose, and if they think that you're going to stop them straight away, they're going to be absolutely terrified. Please be empathic. Consultation skills. Oh dear, she doesn't look too happy. Don't know if this one's going very well. These are the things that we think is important when you're consulting on this subject. You've got to make a compassionate connection with them, that you understand that it can be quite terrifying. It's good to explain that the medical profession has got it wrong over the years with these high doses, and that we're sorry and we're trying to put this damage right. We need to explain the risks of continued use and the very possible benefits, and try and encourage what we call the Epiphany, where they make the connection between higher doses and lower quality of life. They need written information that they can digest in between consultations, and don't rush it. Don't start reducing doses immediately. Give them time to get their heads around it. And also give patients the feeling of empowerment, that they are self-directing the tapering strategy with your guidance. Have a think of it from their side. Their life without opioids, they'll catastrophize that you're going to just stop the medications, the withdrawal symptoms they'll get, and how empty their life will feel. Their psychological state will get destabilized, their pain's going to flare. And are you really taking their pain condition seriously if you're reducing the painkillers? They might be thinking about loss of financial benefits. They might even be selling them, and therefore have a loss of earnings. When patients ask us why they were treated with these high doses of drugs, very often by specialists in the past, they want to know if the prescribing was inappropriate. And, well, on present understanding, the answer is yes. At the time that they were prescribed, the answer was probably no, but we were lied to and misled by drug companies in the 90s and the 2000s to believe that high dosing was the way to go. We know that now not to be true, and we need to wind back the harms that we've done. We're much more relying now on self-management of chronic pain. All the information for patients is on the website, and there's a good evidence base that retraining of mind, body and soul can really help people cope with how they are. Just to recap, this is where it is on the formulary site, and please do explain to patients that this is to be used electronically like a website. There's lots of internal and external links to YouTube clips, and it's a bit more digestible than you might think at first glance. How do patients find our information? Well, if you print out the first of the documents at the bottom of the page, that's a one-page flyer which explains to them just how to get there. So you can leave that with them, hand over to them to do their research, and come back to you in a few weeks to discuss further. It's important to let patients know of the risks of long-term opioids, because it may well be that they're suffering from some of these symptoms and getting them confused with the original condition. These medications change the way that the nervous system interprets pain, and to cut a long story short, they can make and produce chronic widespread pain of their own accord. Narcotic bowel syndrome is a term used for the sometimes very severe GI upsets that patients can have. Falls and fracture risk is really important for our elderly population, even on weaker opioids. That is a real risk. The endocrine clinic is often referred patients with hypotestosteronism and reduced sexual function, and we know from previously that the benefit is weak and biased. Tolerance, dependence and addiction might happen in 10 or 20%, and there are consistent harms in observational studies: worse pain, worse function, worse quality of life, more likely to be out of work, and increased healthcare use. Cornwall has a high suicide rate, and very often patients who die have these drugs inside them. Opioid-induced hyperalgesia is an interesting phenomenon where the pain networks get much more sensitive to sometimes very gentle stimulus and sometimes no stimulus at all, otherwise known as allodynia, meaning that new types of pain can appear separate from the original condition and can produce chronic, severe, widespread pain. This should be suspected when higher doses seem to equate to higher levels of pain. I'm listening back to the narration of this PowerPoint, listening to myself droning on, and I think it's about time that you met Brain Man. This is a really fantastic 1 minute 45 second animation from the Australian group, and it just explains it all beautifully. I think you should watch it in a consultation with a patient. Watch this.
We all accept medicine advances as knowledge grows. In treating chronic non-cancer pain, there's been too much focus on opioid medication and not enough on the most effective ways to improve pain and well-being. Most people taking opioids experience early gains, but it doesn't last. Taking more may seem to help at first, but in fact it makes matters worse. Along with well-known side effects, scientists have also discovered that people taking opioids often develop other problems. They're more likely to fall, have lower sex drive, lower immune function, and poorer quality sleep. There's also an increased risk of accidental overdose and death. We now know that opioids can quickly sensitize the nervous system and actually increase pain. Some people using opioids say it gives them a little bit of comfort, but that's not a reason to remain on them. There are also those who develop addiction, and this makes it very difficult to stop opioids, despite the harms. Knowledge changes. We now know that when it comes to chronic pain, use of these drugs often makes matters worse. Opioids are no longer recommended for chronic non-cancer pain. Instead, get support, get an active recovery plan, and get started.
We're very lucky that a systematic review came out last August 2017, which analysed all of the research about deprescribing of opioids, and in summary, there is good but low quality evidence that opioid dose reduction in chronic pain results in improved pain, improved function, increased quality. So all of the study shows these improvements. However, the methodology of the studies was not particularly great. However, we must bear in mind that there were lots of different types of support for these patients during their dose reduction. And unfortunately, we don't have much of that, but we'll cover what we do have later. Right, back to our consultation. Hopefully it's going a bit better now. We've made an empathic connection. We've described historically how prescribing's gone so wrong, and we've explained the risks and the lack of benefit of continued use, and that there's a good chance that dose reduction may make life better. So next, we need to encourage the epiphany. What we mean by that is encouraging patients towards the self-realization that their life on these high doses is often awful. If their life is fine, then that's a bit different. I mean, there still might be an argument for deprescribing because they might not need those doses as high. But if their life is awful, we've got to come to the conclusion that the drugs really aren't helping very much, and that reducing may well make them feel better. It reduces their risk. And yep, we know that it's scary, but they need to understand that we're there to help them and to try and make their life better. This process takes time. It's not going to happen in an instant. You need to give them written information so they can absorb it and think about it. If they adamantly refuse to believe that lower doses are worth a try, just give them time. Where's the written information? Back in our usual place, Cornwall Formulary website. This is a 2-page document explaining risks and benefits, and also features our friend Brainman, plus the flyer to the patient information. Right, here we go. The things are looking up. We've made the connection. We've encouraged the epiphany. She's had time to mull things over and read about it, and we've decided to go ahead with the dose reduction. So what are the golden rules for the tapering process? Well, you need to review patients often, maybe every 2, 4 or 6 weeks. You can use post-dated scripts in that time, maybe for weekly pickups. Just don't rush things. Taper at a mutually agreed pace. This should be a one-way direction of travel, but you can sort of slow down and stop for a bit if you want. Just remember that you've probably got one shot at this, and if you blow it and you lose trust, then that's a game changer. Remember lots of praise when they do well, because this isn't easy. Should we always consider tapering high doses? Well, yes. If their function's not good, or they got side effects, or they break the opioid contract, or there's drug-seeking behaviour, then you can justify reducing the dose. And even if they're doing quite well and they're not pain-free, but they're coping with life pretty well, then you might be able to reduce the dose and get them onto a lower, safer dose. Make sure you've maximised non-drug and other drug adjuncts, but please be careful not to just switch everyone to gabapentin and pregabalin. Physical therapies, physiotherapy, swimming, yoga, psychological therapies, Outlook Southwest, mindfulness, possibly talking to the pain clinic. Again, it's all in the information for patients. Okay, what about tapering regimens? Well, the ballpark figure for an average dose reduction is 10% every week or 2. You can go faster if the patient hasn't been on the drugs for very long. Maximum speed would be 10% per day, and then much slower, around the region of 5% per month maybe, if they're very anxious about it or physiologically very dependent on the medications. Please warn them that they can expect some flare-ups of the pain after a dose drop, which is just kind of the opposite of they get with dose escalations, that sort of benefit that they get after dose escalations. So the flare usually lasts for a week or 2 only. How to achieve a 10% reduction every so often needs a little bit of mental arithmetic. There's, in the information for clinicians section of the formulary website, you'll find some details about, for example, if you're on a patch and morphine and codeine, how to amalgamate them and make the required reductions here. What's the optimum dose? Good question. In a nutshell, it's the dose which maximises their quality of life. It's the dose that allows them to do the things that the pain prevents them from doing. Sometimes 0 milligrams might be best, or at least spending some time at 0 milligrams to get a baseline idea of functional status, and then a gentle retrial. Aim for the lowest dose, which helps pain function and quality of life, and you can have some immediate release liquid or tablet morphine for use for contingency for flare-ups. There aren't any fixed rules regarding this. This is general practice at its best, with the doctor and the patient seeking out the best path for them. There are different styles. No one's necessarily right or wrong. Just make sure you sort of adhere to these sort of basic rules. Crunch question: how hard do you push? If they're reluctant or just point blank refuse to engage in this idea, well, that's up to you really. That's up to your style. Remember that at the end of the day, you're the one signing the prescription, you're the one giving the prescription, you are in control of the dose, but you might feel uncomfortable going completely against their wishes. Sometimes taking advice is a good option, or maybe use your buddy. Sometimes a good cop, bad cop relationship can work. And if you get stuck and you want some advice from the specialist, the best way of doing this is via a choose and book advice and guidance referral, rather than a face-to-face patient attends clinic type of referral, because very often patients who are referred to specialists with a view of reducing their drugs, they just don't show up to the appointment. So yeah, choose and book advice and guidance, pain clinic. Now, personally, I like this sort of shared decision-making, empathic, gentle approach to patients who are, got a lot of suffering going on. But there are some people who believe that a harder line might be more appropriate. And in fact, there's a surgery in Cornwall who has taken a harder line with their patients on opioids, and they've said to them, look, we're going to be reducing these. We've been told by specialists that high doses are dangerous and potentially damaging to you, and we need to reduce them, and we're going to start reducing them in a month. And if you need to come and see us to talk about this, then that's fine, but otherwise we're going to start reducing in a month, and that's what we're going to do. And actually the reports that I hear, although I haven't got definitive reports, but the reports I hear is that it's all gone fairly well. I'll see if I can get more accurate results and report them back. So what support is there for patients who we're going to deprescribe to, whose emotional lives may well be upset by our proposals and our plans? Well, obviously there's family and friends if available. You might know of some services and support in your area. There's your good self, the general practitioner, and there's the counselling services, Outlook Southwest, community pharmacists. We're beginning to bring on board with this subject. Addiction obviously is a service usually considered for patients using alcohol or street drugs, and might seem inappropriate for your patient group. You can talk to them about it because their key workers are very skilled. There's the expert patient program, I'll tell you about that in a moment, and obviously the pain clinic. I've told you how to access their help. But wouldn't it be nice if there was a well-established county-wide central hub which was up to date with all the services local to you, that would take GP or self-referrals, and it would assess patients and signpost them to whatever activities or services or employment support or poverty assistance that was relevant, and would provide a bespoke package to help that patient build up a life around their pain. It would be the one-stop shop to answer the question, what support is available in my area? Well, it just so happens there is such a service. It's called Inclusion Cornwall, and it's been around for 13 years. I've only just heard about it, which is a bit surprising. You might not know about it, but they're there. You just ring them up. I had a nice long chat on the phone today with them, and patients can self-refer, email or telephone call, and they've got partnerships with hundreds of organisations around the county, and they know exactly what's going on around your area, real time. So yeah, please use them. Thank you. We've got a one-page flyer. I will put it in the information for patients section. The expert patient program is 6 2.5-hour sessions for patients with long-term conditions, which can be a GP or a self-referral, and the link is enclosed. So what are we going to do about weaker opioids? Well, similar concepts and processes as the above, but obviously you're going to have a lot more of these patients. So regarding contacting them, we've got a suggested letter I'll show you in a second. What we're going to do at Perranporth is to, rather than posting, mail-shotting everyone, which will cost a bomb, we're going to put it on our surgery website and we will SMS the link to the patients. So that's document number 5. It's a one-page letter that you can adapt as you see fit, plus the flyer. What about the buprenorphine patches? Well, as you know, the lower dose buprenorphine patches are the same type of oral morphine equivalent as codeine and tramadol, so we should treat that as a weak opioid. Drop the strength of the patch, fill in the gap if you need to with some codeine, and then you can reduce at 10% as and when. Have a think about your systems. Where are the weaknesses in your armour? So might it be patients have learnt to ring up on duty sessions when it's busy and they might be sort of threatening and angry, and the easiest path of least resistance for the doctor is just do a prescription and worry about it later? Or do they target locums or particular colleagues possibly who have more of a propensity to prescribe? This is why we think it's really important to have regular reviews with named clinicians, and filling in lost scripts, dog at it type of stories is just not allowed. It's not on. And apparently Erasmus came up with the line, prevention is better than cure. We want to stop patients getting on these high doses in the first place nowadays. So you can check out part 2 of this series, which is about when to consider using opioids in a management plan and how to do it safely. Just a word of caution, be careful about switching people over to gabapentinoids from opioids. They're only indicated for neuropathic pain, and I'm doing a section in the next video regarding these drugs. So yeah, use them with caution, please. They do have a place, but their place isn't everywhere. Thank you very much for listening. I hope this gives you some ideas about how you can develop a strategy in-house in this difficult, challenging area of medicine. Please feel free to email me if you've got any questions, and good luck.